You're listening to Health is Membership, brought to you by MCAM Architecture and Design. My name's Zach Benedict. I'm an architect working in Northeast Indiana, and I'm sitting down with innovators across the care continuum to examine how we can redefine a culture of health throughout the Midwest. Here we will talk with physicians, economists, urbanists, politicians, poets, and everyone in between to highlight the specific problems facing our communities and consider the most effective ways to ensure their sustainability in the coming years. We are in this together, and we will need each other if we sincerely want to change the trajectory of our communities and work to improve the quality of life for people of all ages and abilities. This show is intended to help cultivate that discussion and remind us that health isn't a metric, it's a membership, one that requires each of us to play a part. There is a number of people concerned about rural healthcare, but none are more passionate about the topic than T. Faircloth. He's a national authority on rural health, telemedicine, disruptive innovations, and health economics, leading multiple forums across the country working to leverage existing assets to improve access to sustainable healthcare in rural communities. A graduate of Vanderbilt University, T started his career on Wall Street and has spent the last 20 years turning around distressed companies. It's a skill set he has now directed towards our nation's health crisis. Once you talk with him, you leave wanting to immediately schedule your next meeting so you can revisit his infectious energy and passion for making a difference. And that's why we invited him to the show. Hello, T.
Hey, how are you, Jack?
Good. How are you? Thanks for doing
I'm
this.
doing well. Thank you.
I wanted to pick your brain a little bit. We try to structure these conversations around some of the complexities surrounding rural health and kind of where they need to start prioritizing some of their energy and where change needs to start to occur. But as we start thinking about this, and you and I have talked about this a lot over the last couple of years, what do you think is some of the bigger challenges facing the rural healthcare system right now?
Coming out of COVID, you've got a time when federal funds were flowing. The federal funds obviously stopped first for those who were least connected. So we're already starting to see the effect at sort of at the ground floor at that rural health clinic level. We're starting to see, problems with, no longer reimburse. How are they going to deal with vaxes without the reimbursement? How are they so we're entering a new phase of sort of survive and move forward for these hospitals as we're sort of coming out of a time when money was free flowing because of the pandemic. We're facing a new sort of era of austerity, and those rural hospitals who have survived and have made it through all else are now facing the next challenge. So it's a huge focus area.
In your experience, what are some of the more underappreciated tools or strategies that these rural systems have that they're not necessarily leveraging probably to their maximum benefit?
Well, in a lot of ways, the system is designed to work against rural hospitals. But where rural hospitals really can take advantage of where they have an advantage vis-a-vis large health systems who are attacking them. The rural hospital relationship with its patient is a much closer and a different relationship, and we ought to be trying to use technology to push care out and keep it away from the big health systems, but keep people closer to home as long as possible. So that's really where rural hospitals can improve, is embracing change and actually embracing technology, but making sure the technology keeps the economics of the delivery of care locally, because disintermediation of the patient and the patient's economics is destructive for rural America.
Give me an example of a technology strategy.
Big health systems are now all pushing hospital at home because they have determined that the hospital is the home is the best place for the hospital to make their money. That's all well and good, except for the fact in rural America and in safety net care, from many patients, the hospital is the worst place to receive care. It's great if you're white and rich and live in the suburbs, um, but they're also trying to expand that hospital at home program to go after and capture rural patients and take those away from the rural health system. The right strategy is for rural hospitals to be using digital health to embrace their patients and keep the patients closer to home and keep them integrated with their local community of care, and don't let the big health systems, prevent the extractive care, the pulling of the economics away from the poorer people and giving it back to rich people.
So is this summarized as a telemedicine strategy, telehealth strategy?
Well, it's more than just telemedicine. It's telemedicine. It's digital health in general. Let's use we have the ability now to digitally push care to the patient. Let's not use that to disintermediate the existing rural healthcare infrastructure. Let's use technology to actually strengthen our infrastructure. Right now, technology is being used for extractive care. They're coming in, they're taking the patient from the existing healthcare system, and they're pulling all those economics away from rural America and just relocating all that profit back into the suburbs. And rural America, 20% of our economy is delivery of care. And how is rural America if rural America is not supposed to be the permanent underclass, how is rural America supposed to survive without its 20% of that economy? And that's really what we're focusing for, is health equity.
How big of an issue is broadband in this discussion?
Overrated.
Yeah, how?
There are workarounds. We don't need broadband on every home. And broadband at every home doesn't make sense. It doesn't make sense to think that a 75-year-old in a fixed income will choose $100 of their fixed income to get broadband to stream Netflix. That's just not realistic. The fact that you can get it, accessibility has a lot to do with affordability. And so people on fixed incomes, people who the government is serving their healthcare needs, they are less likely to be able to have the luxury to spend $100 on broadband, whether or not it is available.
But commonly you hear that is when they talk about the infrastructure of telehealth.
It's rural. We can adapt. We work around things. We work with new tech. We're working with LoRa, which doesn't need Wi-Fi, which needs much less Wi-Fi, with small packet transfers. There's more than just fiber. It's point to point, wireless. There's so many solutions. It's a multimodal world. Let's use multimodal solutions. There's not one size fits all solution for anything.
Is one of the bigger hurdles in this discussion then just the awareness at the local level of what opportunities and platforms there are to deliver care?
There's no model for rural. Like, what is there is, for the last 40 years of federal health policy, there has not been a federal policy to get more care into rural. Every policy has served to remove care from the rural setting and relocate it to the urban setting. What we're trying to do is push a strategy to use technology to keep the care locally. If you keep the patient out of the large health system, large health systems are really efficient money makers. If they get a hold of a patient, they are going to cost a lot of money. And the longer if we can keep that patient local, that's ultimately going to save the health system money, save the government money, improve patients' lives, and keep people alive. When you lose a rural hospital, when a state chooses to let a rural hospital close, the state is making the choice to kill its own citizens because it's not profitable for large health systems. We think that's morally wrong.
If I'm a CEO of a critical access hospital in a rural community, where do you recommend I look towards resources, or because there isn't a model? So what do I do? Where do I go?
I mean, we've been working on the problem for 6 years, so we're obviously have a biased answer, and we definitely have opinions. But I mean, we believe in open source. We think that the future of healthcare software should be open source. It allows for better integration with academia, which is a key component of healthcare. And we think proprietary code isn't right for something as important as healthcare. So we're pushing, open source, sharing, working together. We've been working with the National Rural Health Association on a technology adoption committee. I mean, the NRHA is really leading the way. Brock Slaybaugh does such an amazing job there. They really have done a great job of bringing people together. But yeah, I mean, there aren't that many resources. Software hasn't been designed specifically for critical access hospitals. And if it's a rural hospital CEO, they know the difference in cash flow. And the way critical access hospitals get paid, you need to have a design that works for how that cash flow works.
You made an interesting comment about it being 20% of the economy, essentially.
Yeah.
How much of this problem at the rural level, under the umbrella of sustainability, is more political than it is healthcare driven? You know, is this a topic that is probably also equally underappreciated by rural mayors and city council as it is local healthcare administrators?
Well, I mean, local healthcare administrators live the problem. They absolutely are in, but when you're trying to just stay above water and catch your breath, it's hard to plan for the long term. So it's not a lack of awareness. When you're trying to keep the lights on, you're just trying to keep the lights on. So, counties, like you and I have talked about, the complexity in healthcare is, for AMC care is incredibly great. But when you actually take a complex adaptive system that's designed for one type of cash flow and you then transport it into the critical access hospital model, which has a completely different cash flow, your number of complexities in that whole model is just growing exponentially. So there is so much complexity within healthcare, and especially within rural healthcare, that it's just really hard for a lot of people to sort of figure out which way's up.
Right. Well, and part of my question is an interest in understanding, how often do you see kind of the praise or the excitement when a large system comes and purchases or absorbs, right? And the political capital that can provide in its messaging of it being a good thing without understanding the ramifications of it in terms of its local control.
Well, I mean, in theory, think about it. You are supposed to have a community serving health organization coming in to support a local health organization. That's generally how it's produced. However, large health systems have zero fiduciary duty to the rural patients that they serve. And if you talk to large health system CEOs, because I've discussed their fiduciary duty is to the large health system in the city. So they are making every decision in the financial interest of the large hospital and whatever makes the large health hospital the most money. An example of this currently we're going on is the Rural Emergency Hospital. The Rural Emergency Hospital is the federal government paying large health systems basically a bounty to close down those rural hospitals, turn them into triage centers that then turn around and send their patients into the big cities so that they can make more money. So basically, the federal government is telling large health systems, we will give you a roughly $2.9 million a year bonus if you close down your rural hospital, kill your own citizens, but you'll make more money. And pretty much all the rural health systems are down with that trade. We've talked to a number of rural health systems about the rural emergency hospital model. We have never talked to anybody about the care. We have only talked to business analysts who are putting it in their Excel spreadsheets. And whether or not people in a rural town live or die is decided by a business analyst in a healthcare system in the city. And that business analyst, people's lives should not be a business decision. And that's wrong.
Have you seen any examples of a larger system prioritizing locally controlled decisions? Or is it just an antithesis of the structure?
Well, the structure is a central, the goal is monopolistic, a centralized system. So in the West, they do there's some amazing large health systems, but they're not large urban health systems serving rural. They have always been a mix because you have some really strong health systems in the Mountain West that do a good job with rural, but that is more in nature of, it's not 80% of the money is in one town in a state and all the other towns are the satellites, like you see with the other areas. It's much more of the town to rural gap is not as large as it is in other areas.
It feels like in some way this is a real confusion in cost, because we're talking about revenue and business decisions based out of non-local entities. But it's also this discussion, I think, of not understanding the cost of, the value of an open source system or the social determinants of health intersection with how we design, plan, and build communities, and the quality of life that those decisions impose on marginalized populations. Is that part of what has slowed down any progress of the role setting, is the complexity of talking about this in terms of cost versus revenue? Or is it simply just a David and Goliath kind of mentality of not being able to compete at the level some of these larger systems do?
Oh, we can compete. We can if it were a level playing field, rural hospitals provide better outcomes. It's not that we can't compete. It's that the other team's controlling the refs. Mm-hmm. So it's real hard to compete against a larger team that's got the refs on their side. So give me an example. Every federal policy. Sorry.
Give me an example of that, of how.
Well, let's look. Federal health policy. The most expensive hospital bed in America is an empty critical access hospital bed. Holy cow! What do we do to get rid of the most expensive health hospital bed in America? An empty one. We ought to be filling it. However, there has been zero policies that have done anything other than push care away to create more empty, expensive rural hospital beds. And then they say rural healthcare is just losing money. Mm-hmm. The average rural hospital has 4.2 patients per day, 25 beds. That's by design. That is by policy. That is through regulatory capture. We should be filling the most expensive hospital beds to make them the least expensive, because the dirty little secret is the critical access hospital model works really well, but it's not a for-profit model. It's not a high margin model. It's a low margin community service model, which would be destructive to large health systems if it were able to thrive. So even before the 1997 Balanced Budget Act was put into effect and the critical access hospital program was put into effect, the legislated amount of margin had already been slashed. And now for any type of care inpatient, your net is cost minus 7%. So you're starting with a 7% negative margin. Rural hospitals are getting paid $3,100 a day to take care of a sepsis patient and still losing money by design. That is the design of the program. There is no level. They could be providing 10 times better care than Harvard Medical School could provide, and they would still lose money. It has nothing to do with quality of care. And the lie about value-based care, which is neither value-based nor care, it is a risk transfer business model. That's just wrong. Because if rural independent doctors are the better bearers of risk than United or every other health insurance company, if the insurance company is not the right bearer of risk, but a rural independent doctor is the wrong bearer of risk, we've got a just screwed up model. We've got a corporate controlled model.
Is there a critical path to approach changing this? Does it need to happen in a sequential order, or is it just?
No, there are so many problems that are easily rectified, and so much of it is the light hasn't been shined on it. We've got rural grants where people are getting rural grants and choosing to say, they're telling the federal government we're taking money for rural, and then they're turning around and spending it in urban areas. Now that's telling the federal government you're spending rural money, but you're spending it in urban areas is, I would say, morally wrong. But it's not pictured that way because obviously people in the city need help too. But they don't grok that you're physically taking a dollar and transferring it from rural to urban, which increases the health equity gap between the two. So much of it is really even being aware of the problem. The poorest people in the poorest counties in rural America have had no voice for 160 years.
Right. What role, we've talked about this before, what role do swing beds play in this discussion?
We're a big believer in swing beds because they get the patient back home, get them integrated into their local circle of care. They're more likely to return to the local hospital if they've actually been there. But for a rural health system, it's huge because it actually fills the most expensive beds in healthcare. It's a win-win-win. If a patient comes into a rural hospital, he doesn't readmit it. He readmits at a third the rate of if they go to a SNF. And SNF care is longer, more costly. On a per day basis, it's more expensive for a swing bed, but you're covering those costs anywhere. On a variable cost basis, it's much cheaper for a swing bed.
Are they underutilized?
Incredibly underutilized because large health systems don't want patients to leave they want to keep creating revenue from a patient. So as soon as a large health system gets in to get out of that, to escape their grip, you've got to escape. And so a swing bed that transfers a patient back home doesn't make any money for the big health system. And the idea that large health systems are going to do what's best for the patient, but that's not always their priority. Let's put it that way. Maintaining their care is maintaining control of the patient and the revenue is their priority. So, we have a large health system that has a robust swing bed program in the one hospital that they run, but they refuse to send anyone to any other rural hospital in the state. They want to keep all the revenue.
So if I separate this discussion, it feels like there's two buckets. One is how to improve the locally controlled outcomes of large systems providing care in rural settings. That's one bucket.
Well, how do we keep the economic? We want to keep, because if you're in a city, you should not be pulling economics out of rural into your health system. We had large health systems who, during the CARES Act, would take provider relief funds for their rural hospital, bypass their rural hospital, shove it straight into the profit arm in the city.
So the question is, one issue is to try to understand how to better envision a way that care is provided from a larger system in a rural setting. The other is how to retain the presence of existing critical access hospitals that are, limping along in a rural setting as they are now. Are those different in your mind, or do they intersect to be sustainable?
There should be intersection. I mean, if large health systems would just realize rural is different and we need to approach it differently, they can make so much money. Our initial model was trying to get large health systems to understand that it was more profitable not to destroy rural health systems. And, I had a conversation with, thankfully now a former CFO, who told me, quote, "Why do I want a rural hospital to survive? They're a pain in my ass." And this is the CFO. And I specifically said, well, because then they will be using your emergency department as a primary care physician. He goes, "That's very profitable for us," was his response. So there is a hostility to the very existence of rural hospitals in some ways in a lot of health systems.
Tell me a little bit about the work your team's doing, specifically in how to try to, I think, integrate these two different worlds and build a partnership that might be more sustainable in a rural setting.
A lot of what we're doing is, like I mentioned, it's all based around open source. We've got a whole, a digital platform that includes, obviously telemedicine, but the difference in our telemedicine is we're using rural doctors to actually provide telemedicine to rural patients. That keeps all the economics locally. Here's a great example of design being working against rural. The telemedicine reimbursement model is designed for large cities. In large cities, the provider is the valuable part of the trade, and the patient, there are plenty of patients everywhere. So if you look at the economics of telemedicine, they're designed for the city. The provider gets about 95% of the economics, and the person who controls the patient receives about 5% in the form of a facility fee. Well, In rural America, the valuable part, we can bring in anybody electronically. The providers are commodities. They're not valuable. In rural America, the valuable part is owning the patient. And so we believe the right economics are not 95-5 in rural, but something closer to 40-60. The provider should still be paid more, but we can swap him out with 3,000 other providers. The valuable part of the trade is the rural hospital, which should be capturing more of the economics. So we've designed a model which fixes the broken model for rural. It also has the key part is, rural doctors who see rural patients are going to be better working with the problems faced in rural America. So we think we can improve that. Then we have a whole swing bed program, which actually bypasses large health systems. We work directly with the HIEs so that we can try to get our patients back and make it harder for them to keep patients from returning home. Then we also have a hospital at home program, which is unlike the urban hospital at home, which is designed to keep patients out of rural hospitals. Our model is designed to deal with the more medically complex patients, who are common in rural areas with 5 or more comorbidities. And for those, it's a combination of both RPM plus CCM, but designed in a manner to tie the patient to their local hospital so that they term them frequent flyers, but they're not frequent flyers showing up every 30 days, because that's just not a good way to live for anybody.
Right. Is there a strategy in trying to understand how rural hospitals can work together as more of an integrated system as well?
Yes. I mean,
so how does that work in your mind?
We're building decentralized networks of independent rural hospitals. So we're working in North and South Carolina, we're working with independent hospitals in both states, getting them to work together. In Georgia, and actually throughout the Southeast, we've formed the Agricultural Black Belt Alliance. The Agricultural Black Belt starts in Virginia and goes through Louisiana. It's also known as the Stroke Belt and the Heart Attack Belt. But for the last 160 years, it was the remnants of the slave industry and the plantation industry were all around the Black Belt. And if you look at the CDC Social Vulnerability Index, it's just as clear in 2020 as it was in 1860.
Yep.
And this whole region, parts of the region have been looked at individually, but nobody's looked at the region holistically. And, Allendale County in South Carolina and Randolph County in Georgia are 265 miles away. They have the exact same problems.
Right.
No adjoining counties have their problems. So we're looking at, thanks to technology, we can create networks that are non-geographically contiguous of different, we're creating networks with different challenges. And that way you're actually able to get people working together on the same challenges that face the same challenges.
How is that discussion? Play that out for me. So you're talking to two different, maybe not even neighboring rural health systems, and you just walk up to them both and say, you should be partnering with each other.
No, Allendale has an incredible CEO, and we stay in contact, and he'll talk about some program he's doing. We go to Randolph County and say, here's what they're doing here. Would this solve some of your problems? All of a sudden, Randolph County thinks Allendale's smart. Well, Allendale knows that Randolph County did what they're doing, so they're allied. We're just creating natural networks. It's not a matchmaking. It's you guys are both working on the same problem. Let's solve it together.
Is there any partnerships that will change the course of how the care is locally controlled, do you think?
We really are excited about the Agricultural Black Belt Alliance. We're about ready to launch there in terms of telecommunication, and in that program we've got a physician in sort of Northeast Georgia providing digital care to patients in Southwest Georgia. So if we can show that, and in that 100% of the revenue stays in rural, and in a lot of ways, we're trying to create a closed economic system to keep the money cycling through rural America.
How important is the local healthcare leadership to this equation?
Oh, if you have a good hospital CEO, they're underpaid. I don't care what you pay them.
Right.
They are. The difference in leadership is, what's an extra $10 million worth to your town? mean, when you go to towns with good hospitals and good CEOs, they're 30 to 40% of the economy. They're driving the town. Conversely, when that hospital gets closed for no reason, 40% of their economy disappears overnight. And it's really hard to replace 40% of your economy. If you remember when we had 9% of our economy shrink a couple of years ago, that was kind of devastating.
Right.
Imagine 4 times that, and the effect is kind of exponential and it's permanent. So, yeah.
Is that seems to me to be one of those that is probably one of the most undervalued decisions a community can make as a community, not just a healthcare system, is attraction and retention of those leaders.
Absolutely. And but the great part with rural is because it's overlooked, a lot of non-traditional CEOs have gotten opportunities and have thrived.
Yep.
I would guess 80% of the CEOs we work with who we happen to think are the most innovative are female. Female leadership in the medical space has been historically severely limited. So they're able to get options in rural, and it's to rural's benefit because they're doing great.
Yeah.
So, it's definitely led to some opportunities for people who traditionally have not gotten the deserved opportunities to get their deserved opportunities, and you see them shine. But yeah, the difference in a hospital CEO is 100% the difference in the hospital outcomes.
Of all the problems existing right now in rural settings, what is in front of them over the next 10 years?
Continued attacks on the payment front. I mean, just look at Georgia, for example. We're based in Georgia. The Georgia legislature has determined that it is fine for Blue Cross Blue Shield to be paying Emory north of Medicare rates while paying all of its independent rural hospitals Medicaid rates. Well, shouldn't the legislature care about their rural hospitals? And I would think that they could actually have, rural hospitals aren't that big a percentage of Blue Cross Blue Shield's business. And if they wanted to actually protect rural hospitals, they would just have Blue Cross Blue Shield reimburse at the same rate for Emory and for rural hospitals. But that's not been a political. There's been no political cost.
Right. Do you think universal healthcare will complicate this even further?
Define universal healthcare.
Yeah. And that, I guess, to your point earlier, you could easily imagine a system that is quote unquote universal and make all the same omissions and mistakes in the rural settings that we're making.
Oh, it would make many more because it would be more extractive too.
Right. Exactly.
Our one hope with universal is that they may actually keep the economics tied to the patient, but that would be a big change. Why are patients the economics of healthcare and the patient should not be disintermediated. The economics of that patient's care should benefit that patient's community. It shouldn't benefit rich people's communities. Why?
What changes do you think need to happen in the immediate future in terms of regulation?
Actually, the federal government saying we believe that 20% of healthcare, 20% of that rural should get 20% of the healthcare. That would be huge. There's the federal government's official policy is we're looking to reduce the amount we spend in rural America. Well, that's a silly thing. Shouldn't we be trying to get a representative impact on our economy now that healthcare is 20% of our economy? So, the regulators, their fiduciary duty is to the Medicare trust, not to rural. Regulators have zero interest in rural healthcare surviving. That's not where their loyalty is. Their fiduciary duty is to the trust. So they are looking at the fact that you're killing people isn't, as long as it's saving money for the trust, that's a consideration. But higher mortalities, everything's every decision is a choice of sacrifices, and rural doesn't have a voice to not be every sacrifice, and so everything comes out of rural.
And it's interesting because in some ways, if you looked at this as where the consumers are, the rural voice would be the loudest.
Yeah.
But to their point of not having a voice, where do you think the most effective voice would come from?
Our goal is to have 1,351 hospital CEOs as constituent number one for their representative, because
Okay.
the rural voice has never been heard.
Right.
But rural hospital CEOs, if you're a rural hospital CEO, you're in charge of a business that has zero business having survived this long. Like, you have to be a fighter if you're a rural hospital CEO. If we can get 1,351 voices talking to their representatives on a regular basis and letting rural's wishes be known, we could start to change things in a hurry, because it's a political choice. If there could be a political price, things will start to happen for rural. If there will be no political price, nothing will ever happen.
And to me, that's part of the biggest hurdle in this discussion, is trying to understand and reconcile the political environment surrounding these discussions. And trying as best as you can to have a meaningful conversation within these communities so that they understand the risk and reward of these being locally controlled entities.
Well, what's the risk?
Well, of the risk meaning that they seem to be really excited when they lose it.
No. Well,
the control when they lose,
Yeah, so they are told. Well, for the last 20 years, the regulators have been saying your goal is to get us pretty enough so that the big girl asks you out. That's what they've been told. So yeah, of course. Hey, we improved our hospital so somebody else could make money off of it. That's what they're being told. Logically, it makes no sense.
So when you get 1,351 CEOs to have a voice, what's the message to the political entity that likely doesn't understand the dynamics here?
Keep the economics in rural. Here's what we need. We need rural controlled, rural owned community hospitals, nonprofit, focused to serve, has a fiduciary duty to its community. I asked the federal government on this rural emergency hospital thing that got snuck in a year and a half ago in the middle of the pandemic, who at the federal government would be representing the fiduciary would have the fiduciary duty of the rural town in the decision. A year and a half after they had introduced the program, they had not even considered the rural town's perspective. So if anybody wants to know if rural emergency hospitals were designed to help rural America, they answered that question right there. A year and a half in, no thoughts on the actual town affected, just the healthcare system and the federal government.
Where's your head at now? What's the big focus for you right today?
Our big focus is working. There's still so much money coming from the federal government. We are working on a number of rural economic development initiatives. Economics is health equity. You can't talk about one without the other. So a lot of what we're doing is working with the poorest, most vulnerable counties in America who've never been able to access federal funds, to help them access some federal funds so we can start to build things bottom up and start to improve it from the base.
What other partners are doing supportive work in this kind of space for you?
We've actually done a lot of work recently with the Linux Foundation.
Okay.
It is the software industries.
Yeah.
It's the software industry's open source efforts. They're doing. They spun up the Linux Foundation for Public Health. Jim St. Clair is the executive director. They spun them up during the pandemic, and since then, we've continued to grow our relationship with them, and they understand the value of open source. Open source just works particularly well for rural because you have so much government involvement, you have so much academic involvement, and by being open source, that works for both of their platforms. When you start getting into proprietary code, everybody closes up and nobody works together. So we've pivoted during the pandemic from being fully proprietary code, because we think we have some smart guys developing it, to being fully open source, because that's the right way to do it.
What are some other issues that you know need solved, but you don't know if anybody's working on them?
Oh boy. I mean, the cool part is there's so, like, people re-examine themselves over the last 2 years.
Right.
So, I've got super senior, super smart guys. We're working on, rural connectivity with like the smartest people at Microsoft. They weren't even thinking about like
Right.
the humanity. In a lot of ways, a lot of humanity and technology has sort of come back thanks to this. So the exciting part is people sort of realize, and pre-pandemic, people didn't really appreciate what rural necessarily has to offer. After 2 years, the idea of having 100, living on 100 acres away from everybody, that's appealing to a lot more people. So the good news is we're starting to see, our long-term vision was, with the rise of distributed tech and connectivity, over time, people would start moving further out because their commutes, they would be commuting less often, so their commutes would stay the same on a weekly basis, which is how you determine traffic patterns. But that got accelerated exponentially during the pandemic. So we're actually seeing more wealth moving into rural. It's been slow at first, but it's continuing. That's going to get more political power in rural. It's the golden rule: money drives money. Who has the gold makes the rules. So we're happy to get more focus. But the good news is we're starting to see people who did not have an interest 2 years ago suddenly have an interest in rural America. So that's good.
So last question, maybe.
Maybe.
What's the one bit of advice you give to a rural CEO trying to stay above water? What's the one thing that you want them to try to understand?
Act. It doesn't have to be the right decision. Just make the decision and stick with it. Do the smart thing, do the right thing. Novel concept. I mean, but make a decision, make a choice, and act. It's paralysis by analysis is a huge problem in rural because everybody feels like they're on an island. And you're not alone. Hey, call us. We will introduce you to another CEO who's dealt with the same problem. Like the solutions aren't that hard. Usually they're very commonsensical and sort of too obvious to even look at.
Right.
But choose to act, because if you don't act, you're going to be killed. You can't hide anymore, unfortunately.
And you're running out of time.
Yeah.
Well, T, I can't thank you enough. I really appreciate the work you're doing, and I just find it fascinating. So,
Zach, thank you so much. I learned so much from you. I really appreciate your time.
Looking forward to another conversation sometime soon.
Absolutely. Thank you so much, Zach.
Hey, thank you. Take care.